A very good morning to all of you. I warmly welcome you to another session of our webinar series jointly organized by the GMOA and Shri Knowledge Academy. So without further ado, I would like to introduce to you some housekeeping rules. So the webinar link for today will also be available to you from 9 a.m. to 9:50 a.m. for you to join in. And no late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to begin and obtain the certificate for CPD points, and these CPD points are strictly adhered to the NCCPD guidelines. Please make sure to mute your microphone and also to switch off your video during this webinar to avoid any interruptions. Additionally, as usual, we will be hosting a Q&A session at the end of this webinar. So please feel free to enter any of your queries into the chat box to be discussed at the end of this webinar. Right now, I would like to introduce to you today's topic, which is shortness of breath in the critical care setting. And our distinguished lecturer today is Dr. Dilshan Priyankara, Consultant Intensivist at the National Hospital of Sri Lanka. Over to you, sir.
Good morning, everyone. Thank you very much for that kind words of introduction. And I would like to thank the GMO and the Shri program conducting these academic events online for the medical community. So without wasting your time, especially this lovely Sunday morning, probably run through this my talk and probably 1 hour. So so let me share my screen, please. After that, I'll probably switch off my video because of the connection issue. Right. Hope you all can see the presentation.
Yes, sir, we can see the presentation.
Okay, good. So I selected this topic, shortness of breath in the critical care setting because there's wide variety of disease entities that come with the shortness of breath. But I probably, limit my talk to several interesting cases to look into these patients, how you're going to approach these patients. So start off with because there are a lot of people from different categories who might be in the working as general physicians, maybe doctors working in the wards, emergency department, or maybe in the intensive care unit. So shortness of breath is a very common complaint, especially in the OPDs or maybe in the wards or maybe in the HDUs or quite common in the intensive care units. But the way you look at this, the entity, the shortness of breath may be different when in different settings. Because, for example, in intensive care unit where the patient is intubated and ventilated, patient may not be complaining of shortness of breath. But we look at certain parameters to see how their respiratory and cardiovascular functions are, stabilizing. So different settings will entertain different modalities of, like taking histories, examination, and sophisticated investigations. So shortness of breath, we commonly call dyspnea, is someone may tell it as difficulty in breathing, or maybe manifesting like in air hunger or breathlessness, tightness in the chest, or maybe feeling of suffocation, or maybe some other way. So I would like to carry my talk elaborating few cases, which would be, I thought, interesting to see how in the real setting that you the approach to these patients. So I would like to start off with the case 1, where a 56-year-old man admitted to A&E department following a fall from height, and he was complaining of leg pain and was found to have stable pelvic fracture. And this was managed conservatively, and he had no other injuries except right few rib fractures, and he had a previous history of angina. He's a smoker, and he was treated in the orthopedic ward, and this was actually a real case scenario. And day 2, he developed severe shortness of breath with heaviness in the chest. So you were called to the scene, and when you arrive at the scene, and he was gasping for breath, and he was holding his chest, and he was tachycardic with hypotension, and he was intubated with ongoing resuscitation at the place. And probably you must have seen the resuscitation teams coming there and intubating and resuscitating these patients. It would be really difficult sometimes in ward settings to resuscitate and intubate these patients because the lack of monitoring and sometimes lack of equipment. So it was a challenge. And so the possibilities of this patient's shortness of breath, if you look at the patient who had a trauma and coming with and had a rib fractures and a pelvic fracture now, and day 2 having shortness of breath. He has angina in the past, and he's a smoker, could be an acute coronary event. Maybe it could be a pulmonary embolism, or maybe even sepsis, maybe an hospital-acquired sepsis, or it could be even pneumothorax, hemothorax, where he had rib fractures, and it may even be anaphylaxis to certain medications. So now we have a question. What would you do? So immediately after resuscitation, the patient had undergone an ECG, which showed sinus tachycardia with a right bundle branch block pattern. So then question comes, are you going to send him for a CTPA to rule out pulmonary embolism, or are you going to send him to cardiac catheter lab looking at possibility of acute coronary event, or would you perform a bedside echo to differentiate them? Actually, what we did a focused echo. These are not his images, but just to highlight the importance of echocardiography in these settings. Apical 4-chamber view. On your right, you see, right top, you see the left ventricle, and the down is the left atrium, and the right atrium and the right ventricle. At a glance, what you see is that enlarged right ventricle, where usually the right ventricle is 2/3 of the left ventricle. But if it is close to the left size of the left ventricle, then you know the right ventricle is enlarged. And a sign that you see the right ventricle systolic function seems to be diminished looking at the tricuspid annulus. But if you look at the apex is usually made up by the left ventricle. So there is something happening in the right side. So therefore, the left ventricle acts vigorously, causing we call this sign as a McConnell sign. Then this is the parasternal short axis view. Obviously, you see the right ventricle almost near the size of the left ventricle, and also you see the left ventricle is usually circular in shape at your short axis view, but you see a flattened septum. So there's definite pressure overload on the right side, causing sort of a paradoxical movement on the septum. Then look at the IVZ. So it's very full and it's non-collapsing. So this clearly showed us that there's something going on in the right side, but not in the left side. So the probability of a pulmonary embolism was quite high in this patient. So he was basically treated for empirically for a pulmonary embolism, and later on we did this. He basically had a pulmonary embolism. This is basically a lung scan just to show a subpulmonary consolidation. This is basically due to infarction, pulmonary infarction. You see the pleural lining, and you see a defect here. So just to highlight on pulmonary embolism, because few of you just wanted to highlight on this topic. Pulmonary embolism could be acute. In our setting, where what we commonly see is the acute, or maybe chronic. The acute one is subdivided into massive, submassive, or low risk. why this subdivision is because of the prognosis and the treatment. If you have a patient who is hypotensive, you consider this as a massive PE. Submassive PE, or the patient's blood pressure is normal, or patient does not have hypotension, but patient have evidence of right ventricular dysfunction or evidence of myocardial necrosis suggested by raised troponins. Low risk pulmonary embolism is where you don't have hypotension or you don't have right ventricular dysfunction or myocardial necrosis. So the prognosis and treatment is different, and these three categories. I'm not going into details of the management of each of these, but massive PE warrants either thrombolysis or catheter-related embolectomy. This just the CTPA just to show embolus mainly in the right main pulmonary artery. There's a filling defect. So if you get a hemodynamically unstable patient, so your imaging modality will depend on whether the patient's hemodynamics are okay or not. So if you have a patient who is hemodynamics unstable, where you see whether there's evidence of pulmonary embolism by looking at the right ventricle. Sometimes you can look at the main pulmonary artery to see a clot in the main pulmonary artery. If there's right ventricular overload, there's high probability of pulmonary embolism. Where you have a patient who is stable, you could start transferring for a CT angio. The CT angio would be the gold standard to show whether there is pulmonary embolism or not. So in this scenario, it just suggests that when you look, asking for an echocardiography in the presence of pulmonary embolism, the probability or the sensitivity and specificity high, especially in the massive pulmonary embolism group, rather than the other two groups where you may miss a PE or where you cannot rule out a PE. So going into case 2, a 46-year-old male admitted to A&E with worsening shortness of breath and flu-like illness for 2 days. And he has no comorbidities, and he was a smoker. On arrival, he is tachypnic, and he is also dyspnic. He is tachycardic with 123, and it was irregular. And he was hypotensive with the blood pressure. He had reduced air entry in both bases, mainly on the right more than the left side. So you have a young man coming, smoker, coming with 2 days history of shortness of breath and flu-like illness. He's in atrial fibrillation, hypotensive with some lung signs. An ECGs, so it showed a fast AF. Obviously, there are no sort of ischemic changes. They have done, this was also a real case scenario. Investigations, the arterial blood gas, a very important investigation in any critical care setting, which would tell us what's going wrong with the patient. So this patient's arterial blood gas 60% Venturi showed pH of 7.28, carbon dioxide of 48, and partial pressure of oxygen of 78, bicarbonate of 17, which is low, and base deficit of 8, and raised lactate of 3.5. So he has a mixed metabolic and respiratory acidosis. So the question is, what's going on? Is this patient having pulmonary edema with a cardiogenic shock, or whether there's a COPD exacerbation, or whether it could be just sepsis? So this patient is empirically treated with these 3 treatment modalities. So his AF was treated with IV amiodarone in the ETU and started on IV noradrenaline for hypotension. So the main differential there, the primary differential diagnosis there was whether this could be cardiogenic shock with pulmonary edema. So they were reluctant to give fluids. And they started a furosemide possibility of thinking of pulmonary edema. So what happened after that, his blood pressure further dropped, AF got worsened, and repeat ABG showed a worsening metabolic acidosis with rising lactate, although his oxygen and the carbon dioxide levels were maintained at the same level. So what would you do now? Would you going to increase the noradrenaline because his end organ perfusion is quite low? You're going to give a fluid bolus to this patient, or you're going to intubate, whether you're going to electrical cardioversion because his AF got worsened and rising lactates, or you're going to put him on non-invasive ventilation. So there are a lot of questions that you need to answer to find out what's going on with this patient. So it just what we did was a bedside echo, and it showed good LV function with a fast AF going on and had good right ventricular function. IVC was in normal size, but it was collapsing. And we extended the echocardiogram into the lung ultrasound, which showed right basal consolidation. I don't know whether you can appreciate this. The white line is the diaphragm, above is the lung. Usually lung ultrasound interpretation is by artifacts because it's usually black. And down here is the liver. Now, if you see something like liver here, it's called the hepatization. So very similar to liver, and these white particles are trapped air. So these ultrasound features are more in favor of a right basal consolidation. So actually, this patient had right basal consolidation with AF, probably triggered by the pneumonia, and he was in sepsis and septic shock. So what would you do now? So you might have to give some IV fluids. So your sepsis protocol comes in to play. And you optimize the blood pressure by fluids and optimizing the inotropes and vasopressors, and very importantly, do the cultures and start appropriate antibiotics as for a community acquired pneumonia. So you see that the differentiation may be difficult, but when you have, look at the patient clearly and also with certain investigations, and sometimes your therapy, even without investigations, might show the trend where the patient is going on. But if the patient is not going in the direction that you like to think whether this my diagnosis or differential diagnosis are correct. So look back and think for yourself. So about two cases basically highlights the imaging in critical care setting, especially in the patient who is having respiratory distress and also in the presence of shock. So going into case 3, a 36-year-old man who has a history of asthma, anxiety, and a chronic back pain presented to ED with cough, tachypnea, suggestive of exacerbation of bronchial asthma. And after treatment of 3 hours, he is still tachypnic with mild generalized expiratory wheeze. His blood pressure was 130/80, chest X-ray was clear. The concern was with the persistent hypocapnia. Now, I think this was one of the questions that I given. So these were the blood gases at 7 and after 3 hours. So he remained on the same FiO2, and the oxygenation has improved with treatment, and carbon dioxide has slightly gone down. And if you see his the deterioration is that he is developing a metabolic acidosis with lactate. Now, if you see this ABG without the history, you might think, okay, I might give some fluids to this patient because he's having a possible metabolic acidosis, maybe intravascular volume depletion. So then you think why the patient has oxygenation has improved, by why he's developing a metabolic acidosis, whether his hemodynamics are poor. So then you look at his peripheries, look at the capillary refill time, whether the patient is peripheries are perfused, whether the patient is tachycardic, whether it's maintain the blood pressure. If all are, perfectly all right, then think of other rare possibilities. But actually, this was the lactate rise was due to over-enthusiastic salbutamol therapy. If you look at the lactate is a very common parameter that we look at in intensive care or critical care setting. All of you probably heard of the type A and type B lactic acidosis. Type A usually due to any form of end-organ hypoxia or hypoperfusion. So any patient who is in shock could result in anaerobic metabolism and hyperlactatemia. Also, there are other causes that you have to think. If it is not the case, what could it be? Common scenario that we encounter in our setting is maybe a DKA, maybe a liver failure. Or sometimes we have seen a lot of patients who are on metformin or coming with, especially in the presence of acute kidney injury, coming with raised lactate, but perfectly all right hemodynamics. And also you see the beta stimulation or agonist can cause raised lactate. So the case was basically salbutamol-induced hyperlactatemia. Going on to case 4, a 45-year-old patient admitted to ICU with flu-like symptoms and shortness of breath. For 24 hours, he deteriorated and had to be intubated. He had sinus tachycardia with increasing oxygen demands, and he was intubated and underwent invasive mechanical ventilation. So just want to highlight this chest X-ray. So this was his chest X-ray. You see an endotracheal tube almost close to the carina, so you might have to adjust this endotracheal tube. Ideally, the minimal length that you should allow is at least 2.5 centimeters from the carina, just to allow the extension and flexion of the neck and the head. And the obvious feature in this chest X-ray, what you see, bilateral patchy shadows involving both the lung fields, and he has a right-sided babillus subclavian line inserted and with an NG tube in the stomach. So, and if you see, you can see the air bronchogram as well. So you have certain differential diagnosis. What could this be? So common scenarios that we encounter in our setting is acute respiratory distress syndrome. So could you differentiate it by cardiogenic pulmonary edema? What features you look to differentiate this? So just to point out, pulmonary edema typically begins centrally and in the bilateral peripheral areas, but ARDS is more uniform. Effusions are very rare in ARDS, but you commonly may see with pulmonary edema. And cardiomegaly, if you see cardiomegaly, always suspect pulmonary edema rather than ARDS. And also curly B lines, I would show them, so common in ARDS. And also in both conditions, you might see air bronchogram, because in both conditions, what you get is basically fluid-filled alveoli. So your bronchogram is prominent. Other important thing is the radiographic abnormalities usually closely parallel to the cardiogenic pulmonary edema. For example, if you have a patient in front of you who had cardiogenic pulmonary edema, if you do a chest X-ray, you should see evidence of pulmonary edema. But on the other hand, if you have a patient who is your suspect ARDS, his chest X-ray may not reveal the classic features of ARDS, or it may remain unremarkable a couple of hours. So then you have to go back to the history and see cardiogenic or non-cardiogenic. And also when it disappears, the cardiogenic pulmonary edema quite quickly disappear, where ARDS takes some time. And also residual changes are, we may get residual changes with ARDS, but usually not with pulmonary edema. So these are some of the differentiating features on X-ray. This is a classic X-ray of a pulmonary edema, but there's no obvious cardiomegaly. But if you see bilateral hilar shadows with air bronchogram and also some fluid in the fissures, then you correlate with the history. These are the curly B lines. This is the septal fluid. You see the horizontal mainly seen in the peripheries. And if you now the other importance of looking at a chest X-ray in an ICU setting or in a patient who is supine, who is unwell, the things that you have to look into is the poor inspiratory effort. Because of this, you may get abnormal findings that you may interpret as as sort of a disease entity. For example, because these are usually AP films, and you might see sort of cardiomegaly or a mass aortic arch or patchy of pacification in both lower zones. So this is actually normal X-ray. Because of the supine nature, it might appear abnormal. So the things that may appear abnormal: apparent cardiomegaly, high abnormalities, and sometimes the mediastinum may look widened, and lung parenchyma tends to appear in increased density. So be careful when you interpret a supine chest X-ray, especially in a patient who is critically ill. If you look at this chest X-ray, the obvious abnormality we see is there's some opacification and bilateral, both in bilateral lung fields, but you really can't tell what it is. So again, this is a patient who is intubated, and so probably an epifill. So this is the appearance of pleural effusion, because when you supine, the fluid goes down, the air comes on top, so it disperses. So it's not the classic pleural effusion that you see on an erect fill. So so then if you have a doubt, always do a lung ultrasound and see whether it's an effusion or not. Any idea of this? The patient who is intubated was a central line. The obvious abnormality here is you see sort of a dark right lung field, and you see a clear liver border. So what this is again a patient who is in supine position. So this is, and you see the costophrenic angle on the right side is very, very prominent. So this is called the deep sulcus sign of a pneumothorax, where you may not appreciate the lung border, where again in the supine film the air comes on top. So this is the appearance, the translucency, or you might see the clear borders of the liver or spleen either side, or depending on the side of the pneumothorax. So this patient needs possibly intercostal tube, because the patient is being having positive pressure ventilation. This is another interesting chest radiograph. It's an actual one. This child who had scoliosis correction coming post-operatively into the intensive care unit, the chest X-ray looks like this. So you see an appearance like a pneumothorax, but if you clearly see there are some lung markings on the left lung. This could be due to rotation of organs, and so what we did, we basically did lung ultrasound to differentiate whether there's pneumothorax or not. So there was this seashore sign showing there was no pneumothorax. The other, the pitfalls, again, if you see this chest X-ray, you might see a line here. You misinterpret as a pneumothorax, but actually if you trace it down, it's a skin fold. So if it goes beyond the lung field, think twice. This could be may not be a pneumothorax, and also on the other hand, you might see the other clinical features of a possible pneumothorax. So coming into my last case, pulmonary hypertension, admitted to emergency department again with 24-hour history of increasing shortness of breath and non-productive cough. Baseline, she's on 80 liters of home oxygen, and medications include epoprostenol, infusion via abdominal catheter for her pulmonary hypertension. On arrival to ED, patient had severe shortness of breath with peripheral cyanosis. Saturation was 75%, and patient is tachypneic with her 8 liters of oxygen. On physical examination, the patient has pitting edema, and patient was switched to a nasal high flow. Saturation has improved to 89%. And she's febrile at the tachycardia with hypotension. So it's a lady in her 60s with primary pulmonary hypertension who is on pulmonary vasodilate, coming with shortness of breath, hypotension, and fever. So this was blood gas. Electrolytes were all right, and she has raised lactates with metabolic acidosis with low bicarbonate, and she was compensating for the hypoxia and metabolic acidosis. Troponin is normal, urea is slightly raised. On the chest X-ray graph, you see right thyroid consolidation. Probably, so with the given history, this patient probably might be having a community acquired pneumonia with sepsis, with septic shock, bleeding into septic shock. So she is in oxygenation failure and also with compromised hemodynamics. So the ECG, quite common to see these patterns: right bundle branch block, right axis deviation, and some anterior T inversions, all typical of this right heart strain. So possibly this patient might be having a long-standing pulmonary hypertension with evidence of possible right ventricular involvement. So what would you do to her hypotension? So her oxygenation has improved. What you gonna do? Bolus of Hartmann, maybe 500, maybe 250. I'm gonna start her on dobutamine infusion just to get the heart going, or maybe start on noradrenaline infusion of sepsis and leading into sepsis-induced hypotension. So the thing with the pulmonary hypertension, pulmonary arterial hypertension, which is defined as elevated pulmonary artery pressure more than 25 at rest, usually assessed by right heart catheterization. And usually the patients who have pulmonary hypertension most of the time will have evidence of left ventricular dysfunction or maybe a patient with COPD. So what happens when you have elevated pulmonary arterial pressure? It causes a right ventricle to dilate and eventually undergoes hypertrophy. All of you probably heard of this Frank-Starling relationship, the preload versus the stroke volume in ventricle. So this curve, at this level, point, at the steep part of the curve, when you give fluids, the stroke volume improves. But at the plateau part of the curve, when you give the same amount of fluid, your stroke volume will not improve. So on the other hand, if you give fluids and the plateau part of the curve, it may extravasate probably into the lungs. So the difficulty is try to find out where the patient is actually in. So idea of a fluid is basically to improve the stroke volume, not to reduce the tachycardia, not to improve the blood pressure, but to improve the stroke volume. So if you, ideally speaking, if you tell the patient is fluid responsive, the patient should improve the stroke volume. Whether the stroke volume improves the microhemodynamics, we don't know, but it will definitely improve the macrohemodynamics. In a failing heart, if you give the same fluid compared to a normal person where the plateau part is quite obvious in this patient, so definitely these patients may go into fail. So that's why when you are giving a fluid challenge to a patient who is in maybe in left or right ventricular dysfunction, be careful. There's no hard and fast rule that you can't give fluids, but you give, but always reassess for adverse effects. So there's a thing called ventricular interdependence. So in our body, almost all the organs are interconnected. Dysfunction of one organ may lead to a dysfunction of another organ. And even within the heart, dysfunction of one ventricle may lead to a disorder of the other. It's what you call the ventricular interdependence. For example, in this case, when the right heart dilates, it causes bowing into the left ventricle, and it decreases the left ventricular filling, and therefore it reduces the cardiac output. So that's why the patient gets hypotension. And when you have progressive dilatation of the right ventricle in a chronic patient, the tricuspid valve, the distortion of the tricuspid valve will lead to a functional regurgitation and further decreases the right ventricular cardiac output. So this phenomenon or the interactions are important when you sort of manage these patients. So this is a vicious cycle. If you have a right ventricular overload, cause bulging of the septum into the left ventricular cavity, which reduce the left ventricular filling and reduce the left ventricular cardiac output. And further, when you reduce the cardiac output through left ventricle, it reduces the right ventricular perfusion because through the coronaries. So because of right ventricular overload, you may have increased pulmonary vascular resistance. Then further, it causes hypertrophy, increased right wall tension, and causes right ventricular ischemia. Then further leads to reduction in right ventricular output. So it's a vicious cycle. If you have a patient who is in sort of right ventricular failure, it's a challenging situation to manage, and especially in the presence of hypoxia, because the hypoxia is going to further reduce the or increase the pulmonary vascular resistance, therefore increasing the workload of the right ventricle. So it's a real challenge in managing these patients. So if you come across these patients, so always when you use fluid boluses, use careful fluid boluses. Hypoxia and hypercapnia causes pulmonary vasoconstriction and may increase the right ventricular pressure. And now in this case, you have a systemic vasodilatation. So it will decrease the right ventricular perfusion and further decrease the right ventricular cardiac output. So be careful. In pulmonary hypertension with right ventricular failure, intubation must be seen as the absolute last resort, because if you put them on positive pressure ventilation, you're going to compromise your pulmonary circulation. May improve the oxygenation, but it may compromise the right or the pulmonary circulation, and further or may go into pulmonary hypertensive crisis with right ventricular failure. So I have highlighted a couple of cases with different clinical scenarios where you see diversity of the presentations and also problems which you encounter during the management. So take-home messages. Shortness of breath is a very common complaint in the emergency department, intensive care units, and even in the wards. So differential diagnosis is extensive. This 1 hour or 45-minute lecture is not enough, but I hope that this will stimulate you to read on different clinical scenarios in different clinical settings. I'm basically highlighting these cases on a critical care setting. And results of diversity of disease processes. So to think about that also. And management is not always straightforward. Always think again whether this is correct or not. And also widespread adoption of new technologies will definitely will help you to manage these clinical entities. So I will probably end my talk. So thank you very much for listening to me. Over to you.
Thank you very much, sir, for that very informative lecture. We have not yet received any questions as such to be answered during the Q&A session.
Yeah, I'll probably, now there were a couple of questions sent before the presentation, so I'll probably take a couple of things. There's a real, there's always query about this happy hypoxia in COVID patients. The exact mechanism we really don't know. There are several hypotheses in happy hypoxia in this patient. Some believe it's due to an autonomic disturbance, because the sensation of dyspnea is basically the respiration is basically regulated at the brain or the medulla. So autonomic system is basically involved in regulation of this. So don't know whether it's a part of that. And also, especially if you see the COVID patients who have sort of L-type lung, who had a good compliance, their hypoxia is probably thought due to shunts. Now, if you see patients who have right to left shunts, maybe pulmonary, maybe cardiac, and in your community, they might be having lower saturations, but I mean, they don't look as they are dyspneic. So it may be the same pathology that is going on in these patients. So really, we don't know why they are really hypoxic. There are a couple of questions in the chat box. I can see clinically how we decide fluid responsiveness. Assessing fluid responsiveness is a major challenge. Now, if you are in a setting where you don't have so many equipments, probably an ultrasound scan, go back to your clinicals and see whether your clinical features of dehydration is present. Look at the capillary refill time, and whether a patient has a very low thready pulse. If you have a patient with a low thready pulse, there are only few possibilities. One thing is patient may be hypovolemic. Other possibilities, a patient may be in cardiogenic shock. So think of that, and then you look at the other clinical parameters of tachycardia, and then last the blood pressure, because blood pressure is a compensatory mechanism. So the tendency is basically not to go for static parameters, but if you don't have any equipments, go by your clinical sense. And if you have equipments, looking at doing focus is basically point of care ultrasound. So looking at the heart and IVC and maybe the lungs, it might give us a clue. Other important thing is when you're looking in the IVC, don't just look at the IVC, because the IVC will tell you what's happening on the right side of the heart. So always better to look at the left ventricle as well. So fluid responsiveness means, as I told you, the patient is in the steep part of the Frank-Starling curve. So when you give a fluid challenge, the things you would do is basically leg raise test that you cannot do. In sometimes when you interpret that, also it has challenges. So ideally, there should be a method that to show that this fluid is going to improve the stroke volume. So if you don't have those sophisticated equipments, go by the clinicals, and also the blood gases. Sometimes you see a patient who is in metabolic acidosis. The metabolic acidosis has improved with your fluid challenge, and the lactate has come down. The other important thing is, I see a lot of people give furosemide whenever patient is dyspneic. Whatever the cause, you hear a bit of fine trips, you give furosemide, and sometimes that may be the end of the story, especially who is compensating for the hypotension due to volume depletion. So when you are using furosemide, always use, if you have clear evidence that the patient is either volume overload or either patient is in cardiogenic shock with the pulmonary edema. Don't ever treat acute kidney injury or dyspnea with furosemide. There's thing called negative pressure pulmonary edema. Negative pressure pulmonary edema is another form of pulmonary edema that you see. I think I gave you a question also. So someone now sometimes in the patient, when they are intubated and who had developed pulmonary edema, you may do suctioning through the endotracheal tube, which you should not do. And basically in negative pressure pulmonary edema, the thing you do is basically supplementary oxygen, and if it worsens, you might give a bit of CPAP. And also, there are any other questions? If shortness of breath is the only symptom, do we need to always exclude COVID-19? That's a difficult question, but I think you have to bear in mind that COVID-19 may be present. But if you have a COVID-19 patient who is short of breath, usually they will have X-ray changes. So look at that, and also look at the clinical history. If the patient is having heart failure and AKI, how can we give fluid? So you have to assess the cardiac function by the imaging. A patient who is in heart failure with a pulmonary edema and also with an AKI, you may give diuretics because it might improve AKI. Because if the root cause for the AKI is cardiogenic shock or the failing heart, you have to offload the heart. So offload, and also the back pressure. So none of the organs would like back pressures. The higher CVPs, I mean, for example, if you have higher CVP, the brain doesn't like, you get cerebral edema. If you have higher pulmonary pressures, the lung doesn't like. If you have high pressures on the back on the liver, it causes congestive hepatopathy. So likewise, the kidney also doesn't like it. So you might treat with diuretics if the root cause is cardiogenic. Yeah, I think that's it. Probably the questions.
I think that's it. The questions for today. On behalf of GMOA and also the Shri Knowledge Academy, I would like to extend my sincere thanks and also gratitude for taking your time today, this Sunday morning, to deliver us this very comprehensive lecture, even taking time from your busy schedule. I would also like to thank our very interactive participants for coming together again on a Sunday morning to join with us and learn and explore the knowledge through the Shri Knowledge Academy. Hope to see you all next Sunday with another webinar with an interesting topic and an interactive session. Thank you very much, and thank you very much, sir.
Thank you.